All right, so don't just do something, stand there is the title of this next talk. I didn't write this, amazingly, but I take credit for the saying. I've been saying it for a long time. But I got to say, it's not, what I mean by that is not exactly what's in this chapter. So before I get to the chapter, I'm going to tell you what I mean by don't just do something, stand there. I was just sitting outside with Danny. Dan Bucata is one of Rick's sons. So many of you know Rick Bucata, who's not here with us at the course, but he owns this whole thing, and this is his family business, actually. And Dan and Ricky, his son, his two sons, work for the company, and so does his brother Mark, and so does his sister Jerry, and it's like, you know, his poodle works for the company. It's a family business. And they're all great kids. And Dan was out there, and I was just talking with him about his 2-year-old, and he was telling me the story about how his 2-year-old fell off a little ledge, you know, a little place that he was on, while Rick's wife, Diane, was watching him. Because we were talking about how in the ER we see all the time kids who are injured, and everybody wants to think the parents are bad parents, but you can't watch a kid 24/7 every second, and kids, things happen to them. So his mom was actually watching the baby, and the baby fell off and had a big goose egg on his brow, and they didn't go to the ER. And I was suggesting that what would have happened had they gone to the ER is that most likely somebody would have done a CT scan, and that wouldn't have been a good idea. And that's what I mean by don't just do something, stand there. What I mean is the bigger picture, the conceptual idea that when things happen and you're not sure what's going on, and particularly when somebody's sick, much sicker than just a bump on the brow, you know, with a big goose egg, is our natural human inclination is to do something. That's why the old saying is, don't just stand there, do something, as though flapping your wings and doing Brownian motion actually helps anything. But of course, it not only doesn't help, it often hurts. So I think it's really important for us to get the concept that just because there's danger doesn't mean you should find something to do. And most of the time what you should do is think. Stand there and think. And most of the time what that should lead you to do is watch and wait. Unfortunately, that's not our natural instincts, I don't think. And it's certainly not our instincts in our society where we're constantly told, you got to do something. So I think this is a really important concept. That being said, it's not exactly the content of this chapter. This chapter is about a few minor things that we've always done. We do them because we're supposed to do them. And guess what? It turns out they're not terribly useful. And so if you're on the boards, if you're going to take the boards in emergency medicine, and the case is as follows. Patient has something. What are the first thing you do? What do you have to do? Come on, you have to do this. Every resident knows this when they're taking mock boards. The first thing they say is, as I walk into the room, what do I see? But they also, even while they're doing that, they say what they're going to do. What are they going to do? IV, O2 monitor, right? You have to say that, right? Otherwise you get flunked. And so this chapter says they're all wrong. Now, of course, they're not wrong in the right patient. They're just wrong in most patients. So let's start out with this. The first one is about O2. There's a half dozen articles. There's 3 articles in this chapter. There's lots more that say routine use of O2 isn't helpful. That you need O2 for hypoxia. And what you need to do is not correct back to normal, but correct back to okay, adequate. And even there's precious little evidence that it actually does benefit unless the person's really, really hypoxic. We can tolerate hypoxia for a long period of time. We just can't tolerate it forever. Children, probably they can tolerate it less. Hypoxia is a big deal in kids. But in any case, somebody's hypoxic, sure, give them some oxygen. But most of the patients who get oxygen in the ER in America are not hypoxic, they're patients. That's why they get it. Just in case. So then these articles say, whoa, that's really dangerous. And of course it's not dangerous. If it was dangerous, we'd all have been killing lots of patients by now, right? Nobody, In this room, we've put on oxygen in 700 billion patients combined, right? How many of them stop breathing? So we all learned in medical school that in COPD you can decrease the breathing drive by oxygenating them, and that's true, and it's only in very few COPDers and almost nobody else. So it's not really dangerous. And a couple of these articles tell us why theoretically it could be dangerous. And I already told you what I think about pathophysiologic reasoning with no evidence. So I'm pretty sure, that given our combined experience, if oxygen was dangerous, we would know about it. I don't think it's dangerous. It's just unnecessary most of the time. The next one is about IV. IV O2. So it's really about fluids. So why do we use fluids? I think, personally, that fluids are the only treatment of hypotension that works, of shock. There's some exceptions. Epi is good for anaphylaxis. But other than that, I don't know of any shock which is treated by anything but fluids. Now, of course, cardiogenic shock, they die. And the reason they die is because they need fluids to survive, and fluids will kill them. So we do these very complicated things with pressors and vasodilators and all that other stuff, and it doesn't work. They die. 95% of people in cardiogenic shock end up dying because they're too sick, and our only good intervention doesn't really work. So I'm a big fan of fluids, and I think I just heard Jim say what I strongly believe, which is that when you have sick kids, fluids are really important, and aggressive fluids are really important, and not just kids, but also adults. So I don't mean to say we shouldn't use fluids. Of course we should. I already told you before that I don't know of any evidence that pressors work or inotropes work for anything other than anaphylaxis. So fluids really, really, really important. But we use them lots and lots and lots of times when people aren't sick. And why do we do it? Because we're worried. They could be sick. Or because it's convenient. Get it in now, you won't have to worry later if anything happens. And that's not always terrible. It might be useful in some cases. You have somebody who's really teetering on the edge and you really are worried, sure, be prepared. There are people where you put the defibrillator at the bedside, or you put pads on the front and back because you don't do it on everybody. Sure, this is not a blanket condemnation, but what do these articles say? They say in most of the things where we've given fluids traditionally because it sort of seems like a good idea, it doesn't work. And when we start IVs, we don't use them most of the time. Oh, and by the way, even when you do TKO, a lot of times the patient ends up getting a lot of fluids, which probably is no big deal. There are very few patients who can't get fluids. I mean, congestive heart failure, you shouldn't be giving lots of fluids. And sometimes renal failure, you don't want to give lots of fluids. But for the most part, all of us can handle a little extra fluid, so I'm not worried about too much. Again, these articles tend to say two things. Unnecessary, yes. Dangerous, I don't think so. So the first article talks about fluids and renal colic. And I'm very bad. I'm not good around the house. I don't do a lot of fixing things. And I'm really dangerous with plumbing. So, it's not a good idea for me to say. But even I understand that if a pipe is clogged, and there are two, you got a pipe and it splits off into two things, and one of them is clogged, forcing a lot of water in won't work. It won't push that down. It'll just go down the other pipe. So renal colic, there's this notion you should give them lots and lots of fluids because it will somehow push the calculus through. And of course it doesn't work. Almost all of the fluid goes down the other side. And what's more, you increase pain because you put a pressure head behind the side that is already hurting. So fluids are not great for renal colic. There any other things? Oh yeah, gastroenteritis, IVs. Pediatric gastroenteritis, I think we all know this. We shouldn't be using IV therapy unless you have no choice, which would be 10% of kids. Kids really sick, of course, put in an IV. the kid will not take fluids or just continues to vomit, yes, kids can get really sick from being badly dehydrated. And if you need to give them an IV, you can give them an IV. But the vast majority don't need it. So what do you guys do with kids with gastroenteritis? What's your best trick? Zofran. Okay, anything else? How do you give them fluids? So PO, but what do you do? How do you get them to fluid? The kid's miserable, doesn't want much. So the first thing is have mom do it. That's the most important. And really important with that is teach the mom that she has to be really patient. And if she gives the kid a lot of fluids, he's going to vomit. And that is counterproductive. So go really slow, a little tiny bit at a time. My favorite thing when a kid will take it is popsicles. Kids like popsicles. They're sweet. They'll eat them. They don't eat them fast. And I think about, way more than half the kids end up fine. And it takes an hour before, and then they perk up, and then they eat a little more, and it's good. But whatever you do yourself, don't you be doing it, have the mom do it, because the kid's going to reject you much more than the kid's going to reject mom. And occasionally, dad is okay. There's a couple articles about how we start lots of IVs in the field that never, ever get used. And then we start lots of IVs in the ER that never, ever get used. Even when they get admitted, they never, ever get used. Then the next one is Foley's. We already talked about this, right? What are the indications for a Foley catheter? When should you put in a Foley? Obstruction, that for us is the huge big ones. There are some chronic uses. You have somebody who's got bed sores and you don't want them to leak. It may be appropriate in a nursing home to use it in that case. There may be people who are at the end of life who it's more comfortable for them. For the most part, that's not true. It's better for them not to have a Foley. I think there probably are some operations, long operations, occasional really sick patient where you want to monitor fluid intake and output. But other than that, they're unnecessary. And our tradition in North America is to put Foleys in anybody who's remotely sick. And it's mostly for us, not for them. And of course, it is associated with catheter urinary tract infections, and that's not a good idea. So your hospital, you can't fix this, right? What you have to do is have your hospital's quality committee, whatever that is, address it and come up with guidelines. Here's where we're going to put in Foleys. Here's where we're going to take out Foleys, because that's equally big. The Foley gets in. Once it's in, it's there for a month. And make it better. It should be pretty straightforward. There are CDC guidelines that are really straightforward about when you need it, when you don't need it, when to take it out. And we should all do this. And as I said, I think we probably will be doing it more as a community because we're going to get paid less. At least we won't be paid for the catheter infection. And if they say the patient was in the hospital an extra day because of the infection, that's a big hit. And by the way, when patients are asked in the ER, what are the procedures they hate the most? What do they come up with? What are the ones they really hate? NG tube, what else? ABGs, what else? Foley catheters. IND of abscess, another one. Fracture reduction, those are painful. We can do, the last two, we can diminish the pain a lot of. I mean, you can with these as well, but they're really noxious, right? So we shouldn't do them unless we need to do them. So NG is really, really unpleasant. How many of you had to have an NG tube as a medical student? Yeah. Yeah, that really was not to teach you about an NG tube. It was to get you used to the fact that you are going to be abused for the next 4 years. And beyond. So we shouldn't be putting down NG tubes if we don't need them. When do you need an NG tube? Do you need it in bowel obstruction? It depends. So when do you need it? So basically, there's good evidence that for most bowel obstructions, it does nothing. We don't need to do it. And that's it doesn't change outcomes at all. And it doesn't change outcome in GI bleeding. That's what these articles are. There's a handful of articles, a lot on them. It doesn't change outcome. And pancreatitis, no effect. The only indication for it is intractable vomiting. What? So, yes, so that sort of goes along with if they're, terribly nauseated and intractably vomiting, you can do it. But the patient who just has an obstruction, it doesn't decrease pain on average, it causes discomfort. I don't want it. You don't want it. I can't even understand how it works at all, because if you think about it, you got an obstruction way down here, and you put a tube in that stops up here. What is it doing? Well, the best it can do is remove things proximal to the obstruction. It's not going to fix anything, and maybe that will make them feel a little more comfortable, but a lot of times it doesn't make them more comfortable for the obvious reason. They already have a way of getting rid of the proximal stuff. They vomit. This doesn't actually fix anything. So I think it's perfectly reasonable if the patient is feeling really, really miserable and they keep vomiting and they're really nauseous to do it. But other than that, I don't see any reason. It has no diagnostic value in GI bleeds. There's a couple articles in there which says it doesn't distinguish lower from upper bleeds. It doesn't make the endoscopy any better. And endoscopy is what you need. The thought was, well, they won't be able to see, do this, and it'll make it better. It doesn't. So we should be putting in far fewer NG tubes. And then the last one, I think it's the last one, is ABGs. Jim was just talking about lactates. When I started out in medicine. When I was a medicine resident, one of my tools that I learned was to analyze blood gases. I could tell you about triple acidoses and combined metabolic acidosis, respiratory alkalosis, respiratory acid. It was a mixed acidosis. We had all this. We spent all this time looking at blood gases and figuring out what it was. And I don't think I've ever used it once in my career. And so I don't think measuring acid is terribly useful the vast majority of the time. When I was a resident as well, we were taught that you treated acidosis. And of course, we learned that that actually makes things worse for DKA, makes things worse for cardiac arrest. It's not a good idea. You don't treat the acidosis, you treat the disease. Treating the acidosis is useless. So there are times, though, that you'd like to know about acidosis. The case that Jim just talked about, it's reasonable. You don't need a lactate, but what else was it going to be? Was that DKA? No, it was lactic acidosis. That's pretty obvious. So the lactate wasn't terribly useful, except to get the idiot consultant to come to the ER. Otherwise, it had no use at all. But occasionally you want to see what a pH is. I don't want to see it very often, but occasionally you want to see what a pH is. But you don't need an ABG to find out what a pH is. That's what the rest of this chapter says, is that VBGs correlate very, very well with ABGs. Now, correlation means that the two sort of match each other. You look at one, they're not perfect. And so you got to know how they relate to each other. The pH in one is a little higher than the other. That's all you need to know. The other thing you need to know, and by the way, the other parts of the ABG, the other important part is the PO2, which we have a pulse oximeter for. So we don't really need an ABG hardly ever at all. Now there might be sometimes, besides correlation, how well they look on average, you want to know, is it reliable? So two things could look on average the same. We got the ABG, the number was 7.4, 7.4, 7.4, 7.4. We got the VBG, it was 7.2, 7.6, 7.2, 7.6. The average is the same, doesn't mean they matched. You got to know, how often were they far apart? Almost always they're not far apart. You have an occasional patient where you're really worried and you're not sure what's going on, and the VBG doesn't seem to make sense to you, okay, get an ABG. But for the most part, it doesn't make sense. So these are some things that we do routinely or have done routinely in emergency medicine, not just emergency medicine, of course, in hospital medicine, that don't really have an indication, turn out not to be helpful, and are painful, not to mention expensive and sometimes misleading. So that's what this chapter says.